Go ahead, ma'am.
Good afternoon, everyone. Welcome to today's Facebook Live session. I am Dr. Keerthana, consultant and fertility specialist at Oasis Fertility, Tolichowki. And today's topic for discussion is evaluation of infertile couple. So, to begin with, evaluation of infertility should focus on the couple and not one or the other partner, regardless of the past reproductive performances. So, as we have discussed in our last section, infertility is defined as failure to get pregnant after 1 year of regular unprotected penetrative intercourse, which usually affects 15% of the couples. And we have four basic goals of management, which are to identify and correct specific causes of infertility whenever possible, and proper evaluation and treatment, and to present accurate information and to dispel the misinformation that is gained from friends, mass media, or internet. And most important thing is to provide emotional support throughout their journey. And so, if we look at the evaluation proper, which includes evaluating a female as well as a male, that is the couple. When it comes to a female, it includes thorough history and complete physical examination, tests for ovulation, tests for ovarian reserve, evaluation of uterine factor, evaluation of tubal, pelvic, and peritoneal factors, and some additional workup. When it comes to a male, it includes thorough history and a complete examination, similarly as done in a female, basic semen analysis, endocrine evaluation, and additional workup. In a female who is aged less than 35 years, evaluation and treatment usually begins after 1 year of regular unprotected intercourse. But when her age is above 35 years, this evaluation and treatment begins after 6 months of intercourse. But in a female who is around 40 years, evaluation and treatment should be initiated immediately without much delay. But when we see in some conditions which are known to cause infertility, like irregular cycles or abnormal uterine bleeding, or they are known or suspected to cause like uterine tubal or any peritoneal disease, or if the female has condition like endometriosis, or there is any suspected male subfertility or any sexual dysfunction, then or there is some genetic or acquired condition wherein that will cause something like diminished ovarian reserve, like the couple having in the past exposure to chemotherapy or radiotherapy, then then the couple is evaluated immediately, and treatment has to be started without much delay. And it is also important to know that it may be also indicated in women who do not have infertility, but to optimize the IVF outcomes, like say for other indications, like if they have recurrent pregnancy loss, or when we need to assess the genetic carrier status of an individual or the couple, wherein when certain evaluation like PGTA is warranted. Coming to aging and fertility, fertility in a female, it peaks between the ages 20 to 24 years and decreases relatively little until approximately age 30 to 32 years, and then declines progressively. As we can see in the next slide, when we look at the age of the female partner, and when we look at the decrease in the fertility rates and the miscarriage rates, we can see that uh, in a woman aged 20 to 29, 25 to 29 years, the decrease in the fertility rate is about 4 to 8% lower, and miscarriage rates in natural conception, miscarriage rate is around 7 to 15%. But in a woman who has her age in between 30 to 34 years, decrease in the fertility rate is around 15 to 19%, and miscarriage rate in the natural conception is around 8 to 21%. And miscarriages in ART cycles is around 15% in a woman when her age is less than 35 years. But when she is in between 35 to 39 years, the decrease in the fertility rate is around 26 to 46% lower, and miscarriage rate in natural conception is around 17 to 28%, but in an ART cycle, it's somewhere close to 30%. In a woman aged 40 to 45 years, the decrease in fertility rate is 95% lower, and miscarriage rate in natural conception is 34 to 52%, and in ART cycles, it's close to 65%. So, it is very important in terms of female age. And when we look at causes of infertility in a female, we have the causes divided as ovulatory dysfunction, which contributes to around 40% of the cases, and tubal and pelvic pathology, which contributes to 40% of the cases, unexplained infertility 10%, and unusual problems 10%. So when we look at the evaluation proper, coming to the female, the thorough history. The first and the foremost important aspect is to know about the age of her menarche and the cycle length, whether the cycles are irregular or regular or irregular. That is, if the cycle duration is in between 25 to 35 days, and the amount of bleeding during menstruation, is there any pain during menstruation, and pain during intercourse. And it is also important to know about usage of any contraceptives, duration of infertility, and coital frequency. Along with that, presence of any sexual dysfunction like decreased libido, pain during intercourse, or any history of any vaginismus. And details about previous fertility treatment and previous pregnancy outcomes, if any, either by natural conception or by ovulation induction. And it is also important to know about the medical disorders like any thyroid disorder or history of any hyperprolactinemia, and presence or absence of any galactorrhea and associated hirsutism, any surgeries in the past, and history of use of any recreational drugs, consumption of tobacco or alcohol. Coming to the after the thorough history, and it is important to know about the ovulatory causes, and these ovulatory dysfunction or the causes, they usually present with menstrual disturbances like oligomenorrhea or amenorrhea. And the first major test that we have to do here is to exclude pregnancy. And most common cause of ovulatory dysfunction in a female in her reproductive age group is some conditions like polycystic ovarian syndrome, obesity, perimenopause, weight gain or weight loss, or excessive stress, excessive exercise, thyroid dysfunction or hyperprolactinemia. Coming to the monitoring of ovulatory function is by knowing her menstrual history, which suggests whether there is any history of amenorrhea or oligomenorrhea. And another method is by using the commercial LH kits, which identifies the mid-cycle LH surge, which usually precedes ovulation by 1 to 2 days. And another method is by keeping a track of the basal body temperature recordings, and which usually predicts ovulation. And the next method is by using transvaginal sonography or by doing a folliculometry, where we can know about the size, number of antral follicles and the developing follicles, progressive follicular growth, and it also provides us a presumptive evidence of ovulation. If by the above methods an ovulation is confirmed, then we need to do some endocrine evaluation by measurement of thyroid stimulating hormone to confirm any thyroid disease, or by measurement of serum prolactin if there is associated galactorrhea, oligomenorrhea, or amenorrhea, and by measurement of serum estradiol levels and measuring the follicle stimulating hormone, which in conditions like premature loss of ovarian function, we can see high FSH and low estradiol levels. And the other test to measure the test of ovarian reserve is by measurement of anti-Mullerian hormone. And if there are signs of androgen excess, then measurement of serum testosterone is also mandatory. So main tests that are done to know the ovarian reserve include the measurement of follicle stimulating hormone and serum estradiol in between day 2 to day 4 of her menses, anti-Mullerian hormone, and antral follicle count. So what is antral follicle count? It is the total number of antral follicles that are seen measuring in between 2 to 10 millimeters in both the ovaries. So after the ovulatory causes the ovulatory dysfunction, which contributes to 40%, the next important cause is the uterine factor, which is seen in a female presenting for infertility evaluation in around 15% of the cases. So, and the most common cause of the uterine factors causing infertility include intrauterine polyps, intrauterine adhesions, and submucosal fibroids. So, how do we assess these uterine factors now? So, assessment is by transvaginal sonography again, which is the best non-invasive imaging modality for the diagnosis of these intrauterine conditions. And the next method is by hysterosalpingosonography, which is a radiographic evaluation of the uterus and the fallopian tubes by injecting a radio contrast dye through the cervix into the uterine cavity, thereby assessing the size and shape of the uterine cavity and size and shape of the cavity, and also helps us to diagnose some conditions like congenital uterine anomalies and the acquired conditions. And the other method is by sonohysterography, which is a non-invasive method to define the size and shape of the uterine cavity. And minimally invasive method include hysteroscopy, which is a gold standard method, and it is a definitive method for the diagnosis and simultaneous treatment of intrauterine pathology. And invasive method is by laparoscopy, which needs general anesthesia, and it helps in the diagnosis of conditions like congenital uterine anomalies, endometriosis, and not only the diagnosis, simultaneous treatment can also be done in the same setting. And after the uterine factors, it is important to know about the tubal factors. So, which is again diagnosed by hysterosalpingography, as we discussed just before, which helps in delineating the tubal architecture and also to analyze if there is any proximal or distal tubal occlusion. And the other method is by hysterosalpingo contrast sonography, which determines the tubal patency with the use of a contrast that is delivered with the help of a transcervical catheter. And hysteroscopic assessment is by observation of the fluid or the air bubble flow into the tubal ostia. And the last method is the laparoscopy, which is a gold standard method with the simultaneous chromoperturbation, helps in analysis of the tubal patency and also look for presence of any tubal factors like fimbrial phimosis or peritubal adhesions, and the simultaneous treatment also done in the same setting. After the tubal factors, it is about the peritoneal factors like endometriosis, pelvic or any adnexal pathology. So, which contribute to unexplained infertility. So, the method is by using laparoscopy, which is the only method for the specific identification of any peritoneal factors that impair fertility and treat simultaneously. Next, after female evaluation, it is important to know about the male evaluation as well. So, normally in a male, sperm production involves normal functioning hypothalamo-pituitary gonadal axis and normal testicular and accessory glands, and there should not be any genetic defect. And coming to the causes of male infertility, which include hypothalamo-pituitary disorders. Next is the primary gonadal disorders or disorders of sperm transport. Hypothalamo-pituitary disorders, which contributes to 1 to 2% of the male infertility cases, and primary gonadal disorders, which contribute to about 30 to 40%, of which the important ones are like Klinefelter syndrome or any Y chromosome microdeletion. And the disorders of the sperm transport include any obstructive pathology caused by any surgical trauma or any infection in the past, which will contribute to another 10 to 20% of the cases. So, how do we evaluate MA? So, which again includes a thorough history taking and a complete physical examination. So, it is important to know about the duration of infertility and the previous fertility treatments, and coital frequency, and history of any sexual dysfunction like any erectile or ejaculatory dysfunction, and developmental history like congenital malformation of genitalia or history of any undescended testis or delayed onset of puberty, and any past history of genitourinary surgeries like any herniorrhaphy, which is usually prone to cause injury to the vas deferens, and history of any mumps orchitis in the childhood or history of any sexually transmitted infections or any history of trauma. It is also important to know about symptoms of lower urinary tract symptoms and erectile and ejaculatory dysfunction, or history of pulmonary diseases or frequent upper respiratory tract infections, or there is any history of chemotherapy exposure, or history of undergoing any radiotherapy or gonadotoxic therapy in the past. In addition, it is also important to know about the medication, the drugs, consumption of any alcohol, exposure to excessive heat or chemicals or pesticide exposure. So, after thorough history and physical examination, the other important aspect is the semen analysis. That is, uh, which has to be at least one semen analysis properly performed. That is, with 2 to 7 days of abstinence collected by masturbation. Uh, and if it's a home collected sample, it is important to keep the sample close to the body temperature, and the sample should be kept for evaluation, or it has to be brought to the laboratory within 30 minutes. And why is that 2 to 7 days of abstinence is important? It is because with short abstinence, there is a tendency to have decrease in the semen volume and the sperm density. But the sperm motility and the concentration, they remain unchanged. But in cases of longer abstinence, it increases the semen volume and the sperm density. But simultaneously, there is also increase in the proportion of immotile and morphologically abnormal sperms. So, as per WHO 2021 guidelines, the important parameters that we look in the semen parameters are whether it has a volume of 1.4 ml and total number of sperms in the ejaculate being 39 million per ejaculate, and concentration of 16 million per ml, with a total motility of 42% and progressive motility of 30% and normal forms being 4%. So, if you are getting your semen analysis done, kindly follow the above instructions and ensure if the cutoffs are met. If there is a deviation in any of the above parameters, it is important to seek an expert help. Next, coming to what is azoospermia. Azoospermia, it is absence of sperm in a centrifuged pellet, which is, and it has to be documented in at least 2 separate occasions. So this is usually seen in 1% of all the men, but in 10 to 15% of the infertile men. So azoospermia, it is generally classified as obstructive azoospermia or non-obstructive azoospermia. And obstructive azoospermia, it is seen in 1/3 of the couples, and here there is a blockage because of a consequence of any severe infection or iatrogenic injury, or there is history of any scrotal or inguinal surgeries, or there is congenital bilateral absence of vas deferens. But you should always remember that in obstructive azoospermia, the sperm production is normal. Only there is a blockade in the outflow tract. But in case of non-obstructive azoospermia, which is seen in around 2/3 of the men, there is intrinsic testicular failure, that is either primary gonadal failure or secondary gonadal failure, or it can be due to some endocrinopathies that suppress the sperm production. And after the semen analysis, the next important evaluation includes endocrine evaluation. That is measurement of follicle stimulating hormone, serum testosterone, luteinizing hormone, and serum estradiol levels. So, for whom do we need these endocrine evaluation? If there is a very grossly abnormal sperm parameters, like the concentration being less than 10 million per ml, or there is history of sexual dysfunction like erectile or ejaculatory dysfunction, or other signs and symptoms that suggest a specific endocrinopathy, then it is important to do the endocrine workup. Next is the urological examination, which is indicated if there is a grossly abnormal semen parameters, or then a thorough physical examination by a urologist or andrologist is recommended. And the radiological evaluation includes transrectal sonography or transscrotal ultrasound or the renal ultrasound. And among the additional workup, The important test to do is something called as DFI, that is DNA Fragmentation Index. So this DFI, it provides a measure of the sperm chromatin and a nuclear integrity. So what are the causes of sperm DNA damage? So it can be because of the environmental factors like endocrine disruptors, like anti-androgens or any toxic compounds, can be because of varicocele, hormonal deficiency, or protein deficiency. And the other important thing is the advanced paternal age, which is above 40 years. And coming to the occupational exposures, like exposure to solvents, wood processing, metal industry workers, or automobile and truck and aircraft mechanics, or those having sedentary or any stressful jobs. And or if there is any genetic inheritance like any mutations or congenital bilateral absence of vas difference, or there is any no genetic condition of having any Robertsonian translocation or Y chromosome deletion. And coming to the lifestyle, the important contributor being from the diet, cigarette smoking, alcohol, recreational drugs, sexually transmitted infections, or any history of injury or infections. Apart from this, medical disorders like diabetes, that is also known to increase the DNA fragmentation. So after a thorough discussion about evaluation in terms of female and male, what to look in a female, what to look in a male, what tests have to be done, uh, it is important to seek an expert help if 1 year of regular unprotected intercourse, uh, pregnancy doesn't happen. So, in many couples, the inability to conceive results in feelings. They have lost control over an important and very personal part of their lives. So, the process of evaluation and the associated uncertainty significantly adds to the burden. So, infertile couples, they often need the opportunity to express their concerns, frustrations, and fears, and support groups can help to meet the need. So, counseling must be an ongoing process during both evaluation and treatment, and regular visits to review and critical results and to outline the recommendations for further evaluation and treatment. They help to ensure that all of the couple's medical, emotional, and financial needs and concerns are addressed effectively in a timely fashion. So, if you have any queries, I'm ready to answer that. So, there's this question: how do you investigate a couple for infertility? So, if female's age is less than 35 and they have tried for the past 1 year regular unprotected penetrative intercourse, that is unprotected in the sense without the use of any barrier contraception or birth control pills, then the first and the foremost test we evaluate in terms of what is her functional ovarian reserve and basic semen analysis, and we check the tubal patency. These are the three important things, along with the additional evaluation in terms of endocrine evaluation, like measurement of serum TSH, prolactin, measurement of sugars, measurement of AMH and FSH and decreased their levels, along with the measurement of functional ovarian reserve, that is the anti-follicular count. So, what are the 5 causes of infertility? As we have discussed, in a female, it can be ovulatory dysfunction, or it can be a tubal or pelvic pathology, or it can be unexplained or the unusual factor. But in case of female, causes of infertility can be originating from the hypothalamus um, uh, pituitary axis, or the gonadal disorder, that is a primary or secondary testicular disorder, or there is an obstruction in the sperm transport. Yeah, thank you everyone.